Well, now we're all here. I'd like to call the meeting to order for the Board of Commissioners for Whitby Health. Basically, we will look to see if we have anybody signing on for public comment, which will be later in the meeting. We'll address that. We do at the end have to go into executive session where we will not make any decisions in voting. It's strictly a discussion on all the RCWs. So at this time, I'd like to go on into our consent agenda.
President Allen, do we want to make note that Greta is on?
Oh, yeah, just so everybody knows that Greta is on Zoom with us. And so she is participating, she's not here in the room, but she is online. All board members are accountable.
Move approval of consent agenda.
Second.
Any discussion? All in favor? Going to call the order, point of order. We do want to rearrange the agenda from what was published. And basically there's 3 items. We'll move item A to item C. We need to resolve or vote or hear about the resolution 40 and 41. So we have our CFO and our attorney on board here. Brad Berg is online. So if you would like to give us an update on the resolutions that are in front of us.
Okay, yes, and so for the commissioners, and have those already been handed out?
Yes.
Everybody has a copy, okay, good. This is a package, so there's 2 separate resolutions. One is for our existing lender Heritage Bank, and the other one is for community or Coastal Community Bank. And so this is a package deal. And Brad Berg is joining us because he's going to be available to answer me the technical questions with respect to the resolutions. What I'm going to just present is something that the board has probably already heard in previous sessions, but just to recap for the public record, the purpose of these resolutions is to authorize me as the acting CFO and Mike as the acting CEO to complete the transactions that have been discussed. And so the recap of the transaction, and again, it's a package deal. So right now we have 6.8 million borrowed on a term loan from Heritage. And then we have, as of late breaking news last night, a verbal approval that's been communicated to our financial advisors from Coastal Bank that they're willing to go ahead with the 10 million. And there's some conditions which will come to us later in writing, but based on what's been presented to me, the basic conditions are the interest rate will be locked until July 20th. And so that gives us basically 1 month to get the deals closed. The other condition you've already heard about is they have the right to do a final review of the final version of the audited financial statements. So those are the 2 biggest that I'm aware of. Once we get the actual, and I'm through our financial advisors have requested a written letter of commitment that documents what's been approved. So anyway, that's the main purpose for these resolutions, is to give Mike and I the green light to go ahead and complete the transaction as it's been agreed and approved. And given the current rate environment, and everybody knows what the Fed did this week, we are highly motivated to move ahead and get this done for the benefit. And let me just make kind of a general comment. The main purpose of these transactions is to provide what I call a safety net reserve on our balance sheet, which buys us some time to make proper decisions strategically and not be in a time crunch and be reacting. This way will give us a little bit more financial stability. So we're Typically, a typical day here at the hospital, if you include debt service, costs the district $350,000 in round numbers per day. So the net new money after this transaction that goes like this, 10 million funding by Coastal, 2 million of that goes to pay down Heritage, which leaves you with 8 million, and then there's going to be about 300,000 in fees to close the deal for all the legal fees and the financial advisor fees. So we'll take that 7.7 million of net new money from this transaction, put it on our balance sheet as a reserve to help us navigate and buy us enough time to make some important decisions on all the other implementations. So with that said, I'm going to stop there and see if the board has any questions of me or of Brad. So Brad's firm did review these resolutions, and they're the ones that prepared.
Right, and that's one of the points I wanted to make, is that we dealt with Foster Garvey, for a long period, and same with having Brad Burke. So we have a good relationship with Brad as our attorney right now. Going forward, it's nice that he is part of this resolution review. What I do like is the fact that this goes along with what Health Tech has brought us, is the whole stability. This goes along with the plan on keeping it stable going forward. It's a stopgap, but well needed, well thought out research. It's not just a haphazard thing that there's been a lot of time we have to put into this, and it will keep us, on a stable footing to be able to go forward, so that people don't worry about whether doors open or not. We'll be here and we'll survive it. And know that. You have a question?
Yeah. Can you review the interest rates and the terms?
Yeah, I don't have those off the top of my head, but there's actually two sections. So one of them is that we put a cap in the resolution that it won't exceed 5.5% on the largest of the two. The lower one is, which is the non-taxable one. The tax exempt portion is actually in the fours. So the blended rate between the two is going to be right around 5.375, which that means we have to close it by July 20th, retain that. So, but yeah, it's a good question.
Yeah, a lot of the interest rates are going over 6 now. So
Yeah.
a little bit a year.
And I think,
You have something else?
No, that's it.
I think the fact that we want to get these approved is the fact that the timeliness of this is so important. We need to get it done yesterday if we could,
Right.
and we can't. But giving this authority to something we've already as a board approved is a concept. Now gives them the authority that when the day is right and the hour is right, you can sign the papers and away we go.
So Brad, would you like to have any input right now? Any comment?
Sure, just to add a little more detail to what Kelly already summarized, there are actually 3 series of bonds, 2 that will be issued to Coastal Bank, 1 the Heritage Bank. As Kelly mentioned, the 2 that are being issued to Coastal Bank will be divided between a taxable component, which is the larger share, approximately 8 million, and the other remaining 2 million will be tax exempt. And then the 3rd series is a series that's being issued to Heritage Bank, and that will be tax exempt. And the interest rate on the Heritage Bank that's specified in the resolution is 4.03%. That particular obligation has a shorter maturity date. That's a 5-year bond. The Coastal Bank bonds will be 10 years with principal being paid throughout the term, but it will mature in 10 years, and Heritage Bank bond will mature in 5 years.
Very helpful.
Any other questions or discussion?
You ready for a motion?
Ready for a motion?
I move approval of resolution 440 as presented to us today.
Second.
Any other discussion? All in favor?
Aye.
Aye. And I move approval of resolution number 441 as presented to us today.
Second.
Second, any discussion? All in favor?
Aye.
Aye.
She's on mute, I think.
No, I said aye.
Okay.
Thank you.
I guess it's-
Let's sign these and make it official.
Okay, well, thank you, Brad, for joining us.
You're welcome. And I think this makes a lot of sense. Will be beneficial to the district.
Thank you,
And
Brad.
thank your
Thank you.
team, Stacy, for all their hard work putting it together.
I'll do that. I appreciate it. Thank you.
Thank you. So going back into our, we do want to discuss search for new commissioner. on the agenda. And so basically, with Nancy leaving us at the end of September, we have time here. We need the whole board's input as far as the procedures that we go through. We need to put together, in my opinion, we need to put together kind of a job description, a little bit of what the role entails. Also, the timeframe, when does the term actually expire?
2025.
So from my understanding, the person coming on will serve the remainder.
And then the eligible term.
Right, so whoever the board does get to pick the new replacement commissioner to take place at the end of September. That person will go until I have to run. So like I said, to be fair to them, I think we really need to put together, the fact that how many, the board meeting, workshop, and then at least 2 meetings. And 10 per month. And then I know Mike had put together a really good little handout for us that had, the roles and responsibility of board members. So I want to get with, Connor to get that thing advertised out there so we can find out. I want to encourage people to put together a resume, who they are, what they do, and what they bring to the board.
I think we should also emphasize it can be anyone in our hospital district.
Yeah, the districts have been dissolved so that we don't have to live in North Woodley, Central Woodley, South Woodley. Anybody on Whidbey Island can actually then put in the resume and apply for that position. So no longer districts. And so I'd like to go around the room if that's okay. James, I'd like to, you're like the newest commissioner. And, some of the things that somebody coming on, I think that you've seen from the time you got on, what's involved. And a lot of times it's an eye opener too on what you talk. So.
Well, fortunately, it takes 2 hours a month.
And Greta, you get to make no comments about anything I had told you in the past about a little time you have to spend here.
You mean the 2 hours a month?
Yeah.
Well, I think we need to get a press release out that explains that we've changed our voting structure and advertise the positions open. And to encourage people to apply.
Yes, so we actually didn't have to kind of set the date that they need to be in by. And then we would set up interviews, where we sit down with them, interview them. And then we would make our decision. It would not take effect until come on October 1. And the other question I have, I read all the RCWs and everything, is that I'd like to report consensus. I would like to see Nancy be part of that interview, helping us put it together. If a commissioner chooses to sign off the board next week, that would be different. Then it would come down to meeting commissioners. If they're still on the board in September, see anything that would keep us from having Nancy involved. Just want to get the board's, opinion on
Will these interviews have to be open to the public if the whole board?
that. That's the other thing is that, or we set them up where the whole board interviews them. I don't know how comfortable they're gonna feel, talking to us. Because they're getting, a lot of the public can be there, press can be there. Do we want to set it up where two commissioners interview the person and that person will go to another area and interview the rest, two more, whatever. So I'm not quite sure how to handle that part. I just want to kind of bounce it off and see what everybody feels.
Ron?
You've been through the interviews part.
Yeah, I've been through the interview part, and we did it with the whole board, and I didn't see a problem with doing it with the whole board. This is just interviewing, and looking at the resumes, but the actual selection,
Has to be done in an open board meeting.
the actual selection has to be done instead of an executive session.
Right, we
Personnel.
we have no, but according to what I was reading in the RCW's advice we got was that we would have to vote on it. Somebody would have to make a motion at an open board meeting to appoint this person.
Ron?
That's,
Is this something that would be better for us to discuss in our work session, the beginning of July, rather than part of this board meeting where we have quite an agenda?
yeah, I mean, that's fine, but basically want to get it out there for, they don't have to decide exactly a day, so wanted to get it out there so everybody has time to think about it. So when we come back to the work session, that it's not something just fresh that we throw out. So I just wanted to throw out different ideas and what the other thing, any comments there?
I think it's a great idea to try to separate it out somehow. I don't know how it's gonna be.
Yeah. So anyway, and I'll double check with Brad Burke on a couple of issues on there, but, anyway, I just wanted everybody to think about it, and then we have our work session, and we needed to get out there.
Mike, how have you found how this been in your experience?
Medical leave, very good job.
Anyway, we'll talk about it at a work session more, but like I said, we just needed to get out there and then pick a date. That we can get it all out, and ask for resumes to come in by a certain time, so we can do that in early July. Okay, we'll move on.
There's a concern that the audience is unable to hear everything. So the audience, I think, is having a hard time hearing us speak
Right now,
right now. So I don't know, John, if you could do anything to help.
I turned the mic up a little bit, but I think we need to have the people come and calibrate the mics again. Take your mask off when you speak. Or just speak with a full voice.
so where is the mic
That
at?
speaker right there.
Right there.
Yeah, but that one's right by the projector.
So Dr. Miller, you're gonna have to tilt your head back when you're talking. So are we ready to move on to our health tech report? Caroline?
Thank you. So a couple of things. So Neil Todhunter, who is our president, was at your work session, okay? You all know that in June. And he has been working with the CFO transition and looking at helping to provide and look for a permanent CFO. John Freeman, who's our associate vice president, continues to work with Kelly and Mike on all of the financial issues. I think there's a weekly phone call with John, right, to look at cash and other things. So I continue to work with Curtis about swing bed, and I think we have all of the framework to do a swing bed scorecard, which hopefully we'll have ready by next month that we can share with you. Joy Smith has been here quite a bit and is scheduled, I believe, again next week. And Joy's primarily been working on revenue cycle and accounts receivable. So Joy is been working very, very actively with the staff, both registration staff and with the staff who are responsible for billing and collections. Faith Jones is looking at potentially a review in August to look at principal care management. So you've already implemented chronic care management through another company. So this would be kind of a different program to look at helping to manage the Medicare population. And Faith is hoping to be here in August to meet with Dr. Miller and then also to see what that might look like. Future support, so Berlin Luna is here actually this week to do an assessment of the clinics. And Frank Stapleton will be doing that financial review. Some of the financial review may take a bit longer, just simply because some of the data that Frank is asking for is not something that you've collected historically, but we're hoping that that will be done within the next month or so. Berlin's report of the clinic operations, of course, will be available sooner than that. And then Phyllis Barnett will be here next week. She's an IT consultant to look at the IT processes and structure. Sherry Deander will be here next month. She'll actually be the representative at the board meeting. Sherry will be working with Shauna on implementing the compliance program. And if it works out, would like to do a 15 to 20 minute education for the board on the board's role in compliance. Okay. What else? Then I will be back and Ernie will be back also next month to do a hospital survey. Education, just another reminder that the brochures are out for the Health Tech Conference in Monterey. That's September 18th through 21st. And I don't know if you all got the brochure, but I know absolutely John has them. So if you're interested, it's a great conference. So that's all I have unless you have questions for me.
Is the conference going to be recorded sessions?
You know, I don't know the answer to that. I don't know. I can find out for you. Yeah, I'm not sure. Any other questions?
I like hearing how involved health tech is.
Thank you.
So many different things going on and bring a lot of expertise to us.
Thank you.
Moving on to medical staff report. Dr. Lemming, you there?
I'm here. Welcome. I can understand what's being said now. That's something, somebody did some magic there. I'd like to present the credentials report for this month. For initial appointments, Sarah Cook, MD, is telepsychiatry provisional. Alexander Castillo Medea, MD, pathology provisional. And Krista Burkhart, ARNP in the Women's Clinic provisional. And Patricia Engel, MD, general surgery provisional.
Approval of the initial appointments.
Second.
Any discussion? All in favor?
Aye.
For advancements, Christopher Richards, MD, telepsychiatry, courtesy staff, and Mark Alter, MD, telepsychiatry to courtesy staff.
Approval of the advancements.
Second.
Any discussion? All in favor?
Aye.
And finally, reappointments, there's just one, John Sherman, MD, in emergency medicine as active staff member.
Move approval of reappointments.
Second.
Any discussion? All in favor?
Aye.
I,
I'd also like to present the final version of the neonatal nurse practitioner request form. You should have all gotten a copy of this. This is for anyone that's going to be managing a pediatric patients after hours, primarily in for C-sections for neonates. But they would also be managing other pediatric patients on call as well.
Move approval of the new, excuse me, I have a lot for words. The new neonatal policy.
Second.
Any discussion, questions, all in favor?
I,
Also, we have a draft of the clinical psychologist initial appointment requirements. This has been reviewed by all the members of the MEC who all agreed that this is acceptable to them. However, it hasn't been completely reviewed by all the medical staff yet. So I'm not sure if we can do final approval on this yet or not, but we do have, since the MEC's already signed off, I encourage if we could go ahead and approve this. I don't know if we're going beyond our bylaws with not having all the members of the medical staff having had a full 30 days to look at it since it's been in its final form.
If we could approve it, it has been looked at by all the members of the executive committee, I believe, and one of the members is here. If we could go ahead and approve it, and if there's anything that needs to be added to it later on. Yes, oh yes, yeah, I've been in heavy discussion with the minute.
Yes, because if we could go ahead and have it approved, then we'd have a final form for the new clinical psychologist applying at this moment right now. So
Traditionally, it goes to MEC first. Has it been to MEC?
Yes.
Yes. And they approve.
the MEC members have all approved it. It's
Okay.
just a matter that generally we have the medical staff have 30 days to review it for if there's any other comments that want to be brought to it. And we just, because it was so short fused, my thought was let's go ahead and if the board's okay with approving it in this form, we can continue to address and entertain any input from the rest of the medical staff, make final or other changes if we need to in the near future.
I didn't see it in our packet. Did I just miss it?
It probably would have come out separately because this has just been reviewed. Heather got it out to all the MEC, actually Michelle and Heather got it out to all the MEC members just in the last day or so. So it may have come out separately after the packet was sent out.
I have it.
Just giving them that.
We have it here. Look at John Sensi.
And Michelle is indicating that the medical staff does not have to pass, it's just MEC forward.
I missed that.
The neonatal nurse practitioner privilege request forms in the packet.
But we're on the clinical.
And only the medical staff, executive committee and the board need to approve this.
All right.
Having heard this discussion, I move approval of the clinical psychologist privilege form.
Second.
Further discussion? All in favor?
Aye.
And we didn't get this, Dr. Kammerer, but I'll have gone sent out.
Yeah, I'm going to abstain until I have a chance to read it.
Or forget, I had it here.
We'll make sure you get a copy of it, Joe.
Okay.
And that's all I have to report on this month.
Any other questions for Dr. Lemmy? Thank you, sir. Moving on to staffing status reports from administration. We'll start out with quality report for Dr. Miller. And then you'll go right into operations and outpatients.
Sean, could you put up those slides, please? Again, thanks to Shannon Harney Bates, our Director of Quality, for preparing the slides. Thanks to Shanna Harney Bates for preparing these slides. Next slide, please. All right, so we're working on updating our policies in policy medical. We have 743 overdue policies. Many of those are probably going to be retired because they're obsolete. Our goal is to get them all done by the end of this year, and our departments are working hard on that. Medication safety, we had 2 medication events in April. These were not serious events of no patient harm. There was 1 fall in April, temporary harm, which meant that we do some kind of intervention. 2 workplace violent events in April. None of them were physical aggression, and there were no injuries, which is a significant improvement from the prior one. Next slide, please. Restraints. We've done a lot of work with our EMR and training to improve our restraint, how we manage restraints for patients. We've had very few patients in which to practice or demonstrate our proficiency in the last month or so. So there hasn't been really much of an opportunity to show how well we're doing, but we expect that will happen in the future. Infection prevention, our infection rate continues to be very, very low. 0.21%. That is exceptional for a hospital. So we're very happy. And Colleen Clam, our infection preventionist, has done a stellar job at tracking and giving us advice and making sure that we are following all the optimal procedures and policies to keep that rate low. With respect to HEDIS, HEDIS is all about tracking patient outcomes in terms of care gaps and whether we're hitting our targets for proper preventative care and chronic care management in our clinic world. We're still awaiting some data to come in from several of our payers. We determined that there were many $100,000 of potential bonuses that we could receive if we were able to do a really good job in this area, and we are working hard to achieve that goal using our partners such as Phreesia and ChartSpan to help us. You'll see on the slide the surveys that are coming up in the next few months. Next slide. And this is just about patient safety and risk mitigation. Just a reminder, we have an event reporting system where anyone can put in an event that they think needs to be evaluated. And that's being used quite a bit. It's great. We can track how our events, what events we're having, and then we involve the entire organization in investigating and resolving them and trying to prevent them from happening again. Significant risks are continued recruiting challenges. Our multiple electronic health records, we know all this. The updated code of conduct has just been completed and is going out for attestation later this month.
All of our employees will sign that.
That's correct. Yes. All of our employees will review
And
it.
this is similar to, you're talking about before, the same thing.
Yes, and our education team has been decimated by staffing shortages. And a lot of our educational programs have been put on hold, but we expect to get an education manager back within about a month. Resume making progress in that area. Next slide, please. These are our patient experience scores that come from Survey Vitals. Slight increase in emergency medicine, slight increase in walk-in clinics, and no change in the outpatient care departments. We will be switching to a new product called Qualtrics later this year. Survey Vitals was taken over, bought out by a company called Qualtrics. It's a much bigger company, and we hope that we'll get actually better better service and better reporting, more user, more specific data that can really help inform our processes. And so we have more to come on that as we learn more about this new company. The next is our HCAP score. This is the hospital patient experience scores. Here you can see that we surpassed the national average in communication, staff responsiveness, information about discharge, communication about medicines, and transitions of care. However, we have opportunities to improve with hospital room cleanliness and quietness, and those who would definitely recommend the hospital, and those who would give the hospital the highest rating. Those are our areas to improve based on scores in January, which are most recent scores. Then the last slide has to do with our medical staff office, and thanks to Heather Dickinson, who's doing a great job with credentialing. We have 11 reappointments, 5 initial appointments for last month, to 258 total credential providers. That concludes the quality report. Any questions?
Any questions? Moving on to operations.
So moving on to operations, this will just be a very high level report. Feel free to ask me questions if you need to. On the pharmacy standpoint, we now accept Kaiser patients for prescriptions. That was a lot of work to get approval by Kaiser, but now patients can go to our pharmacy and get their prescription filled at their Kaiser patients.
Our outpatient pharmacy.
Our outpatient pharmacy, yes, our community pharmacy. On the primary care side, Dr. Danhauer started with us this week. She's an internist. She's working at our Clinton primary care clinic one day. She'll be a nice addition down there. In our Cabot primary care clinic, Dr. Langrock is our new medical director, taking over Dr. Scheib, whose last day was yesterday. Walk-in clinics are now able to provide point of care testing for COVID and flu A and B. Those are rapid tests that if a patient comes in with respiratory symptoms, they can come to our walk-in clinic, get evaluated by our provider, and get tested and know before they leave whether they have COVID or the flu. General surgery, Dr. Engel is starting the first week in August.
Sorry, I was motioning to
And Dr. Pravat is a general surgeon who is interviewing with us at the end of this month. Women's care front, Dr. Baltus is our third OBGYN provider, and she'll be starting with us on a part-time basis next month. Frisia is doing well, our intake solution, and we plan to go organization-wide with that in August. ChartsPan, our chronic care management company, has signed up 600 patients right now. I know there's been some concerns about perhaps they are a little more aggressive than we'd like them to be in their process of recruiting patients, but it's a totally optional program for patients. And they're free to enroll or disenroll at any time if they don't like it.
And I heard from 2 people that they really like ChartsPan. It helps them get appointments when they need them, and they're pleased.
Yeah, it is a great program. It allows professionals, clinical professionals, to reach out to patients with chronic health condition, reach out to them every month and make sure they're doing okay, and help them with their various needs, particularly their social determinants of health needs, not just their medical needs. If it's getting their prescriptions refilled, or transportation issues, or housing issues, or food issues, they can help with all of those, not just medical issues. It's a great program. And then finally, we're trying to work towards starting a behavioral health program under Mike's direction. Dr. King is a clinical psychologist who will be coming on site later this month for interviews. And we're also looking to find a psychiatric mental health nurse practitioner to partner with her to start a behavioral health program. That's all we have.
Any questions? Comments? Thank you. Finance report, Kelly.
Yes, I'm very pleased to report our results for May. So this is before grant income. We're reporting a net gain of 319,000. That compares to 70,000 for April. So a nice increase there. And then we also received 484,000 in grant funds. Tim has more of the details that helps fund the boiler chiller project, and those are state of Washington originated funds. So if you add those two numbers together, the net gain for May was 803,000. So nice progress, good step in the right direction. So on a year-to-date basis, there's two major numbers that are moving in the right direction. The overall gain for the 5 months that ended May was 1.2 million, which was an increase. The same period last year was 540,000. So that those positive results were the combination of two numbers. So we decreased operating expenses for the 5 months this year by 2.3 million compared to the prior year. And part of that was offset, well, half of it was offset by a 1.3 million drop in operating revenue. So, and we'll have a few more comments on that. The impact, we're starting to see a positive impact from the increase in pricing on the Charge Master, which the first round of that was implemented in February. And then we also got from our last cost reports and increases in our RHC reimbursement rates. So those are starting to show results. And so the impact of that is just the month of May compared to April, up 409,000. That's the net patient revenue. And then the tax levy, as everybody knows, on a year-to-date basis, this year we have accrued 2.7 million higher in overall tax levy revenue. So that includes all categories of tax levy. And then on a positive note, 3 of our stats are moving in the right direction. This is year-to-date this year versus last year for the 5-month period. Emergency room visits are up 17%, rehab visits up 23%, and hospice visits are up 21%. On the negative, unfavorable side, the net patient revenue year-to-date for the 5 months is 5.6 million below last year for the same period. And that's been driven by lower patient volumes in pretty much all the other departments except the 3 that I noted that were increases. And so we've got a lot of work to do. Of course, that's driven by the number of providers that we have and a few other factors. So as we improve our recruiting efforts, bringing more providers into this health system, those patient visit numbers and the other related ancillary stats should start coming back up. On the balance sheet side, again, some positive news. At the end of May, we ended with operating cash or cash available for operations, 10.4 million at the same compared to the same period last year, we were at 5.1. So we doubled our operating cash position. And I want to put this in context. An organization this size, based on my experience, Tim's experience, Mike's experience, and others, we should be at a minimum of 150 days of cash. just to be set up so that we're in a proactive way of thinking and not being reactive. And so we ended the month of May at 31 days. As of the close of yesterday, we were at 34 days. So we are moving in the right direction there as well. And I want to put some numbers on what we talked about at the beginning of the meeting. So on the coastal heritage transaction, if all of that does close like it's supposed to, that will net the district roughly $7.7 million. That translates to 20 days of cash on hand. And so that would take us up in the 50 days range. And the related debt service to that. So in terms of new money out of the pending 10 million of new funding from coastal, 2 of that would go to pay down heritage. And so the net new funding in terms of the debt service we would have to owe over 10 years is on 8 million. And the impact of that is on a monthly basis, that's roughly $68,000 of debt service. So if you divide that by 350,000, that's 0.2 days of cash. So it's a pretty small price to pay to have that safety net. So anyway, I'll stop there and take any questions the board might have.
Diane is here from Heritage Bank, and we did pass the resolutions that were needed, so we did that at the beginning of the meeting. Just like the resolutions that we passed, everything before. And then what I hear from you then is that you and Mike have a commitment that when you go leave, you're going to guarantee if we have 150 days of cash on that day. No, we appreciate it. We heard we really appreciate it. So everybody needs a goal.
Actually, I'm glad you keep it that low, because we really want 250.
I know that you only have, you have to commit to staying. That's all I'm getting at. So
Sir.
that will be in the record.
Yes, sir.
Appreciate both. Any other questions or comments for them too? Okay, moving on. IT report, Jim.
And, with your permission, because my list has grown, I kind of just like to do an overarching review of all the areas, just if that's okay.
Yeah.
And not just specifically IT. But in regards to IT, as Carolyn mentioned, Phyllis will be here next week to start doing a lot of interviews with staff and members of the team. We've been talking a lot over the last few weeks and putting together the plan and giving her a lot of information. Some of Dr. Miller and Allie and a number of people have helped provide her so we can do a proper assessment of this department. Why we try to structure it correctly for this size of an organization. So that'll be going on next week. The materials that the board approved at the last board meeting at the work session for the infrastructure that has all been ordered, which was great news. Because we did have to buy some refurbished equipment to get us by until that equipment gets here. So it is on its final legs, so that's greatly appreciated. We're looking forward to starting the plan for hopefully fourth quarter to get the single sign-on implemented. So that is moving forward. We have been in the process of interviewing for IT director. So we've performed 2 interviews. The IT staff, because of the migration to CloudWave that occurred, they missed one of the interviews, so they're actually doing a virtual interview with the second candidate today. And we have one more interview tomorrow. Hopefully, out of those 3 candidates, we'll be able to make a decision moving forward. I think they're all good candidates, so we'll see how once we get all the feedback how that goes. I have added on under my umbrella lab, DI, and EMS. So it's a good fit because I work closely with all these departments and I've always worked closely with them. So there's been a handoff going on the last couple of weeks with Dr. Miller, the lab leader, Stevie, and I, and then Jennifer Markham, the DI leader, and I have having a lot of meetings and discussions and getting a grasp on everything. But as far as lab, the biggest, thing going on there, and there's a lot of things, but the new analyzers are, hopefully we'll get that contract and get those pieces of equipment, because the lab is very tight on space, and these new analyzers are large. So there's a lot of work that has to be done in the lab to make room for these and get these up and operational. DI, the new mobile MRIs out front and then the operation, still working through a few bugs out there, but we have to do a little bit of work on the ground out there, because there's the pad got put in and some of the asphalt got fixed. We've got a ramp that comes down for the patients to go up inside the unit. There's a little bit of a slope there, so we got to cut away some of that asphalt out there and get that leveled and prevent the ponding that's occurring when it does rain. And then we're still continuing to work, we're waiting to get some of the details on the Siemens contract finalized so that we can continue to move forward with the new CT, the new fluoro, and the new X-ray. I'm expecting to have electrical bids hopefully this week. They're waiting on a few components to finalize that bid. So lots going on in that part of in that area. One big thing that is happening with the PACS, Philips is doing a upgrade, because we're about 4 versions behind, so that'll help a lot with that. It'll help with speed and better images. We are, hopefully by the end of this month, we will have remote access to all providers to get into PACS. Right now, AJ is working very hard to get that completed. Philips came up with a solution, so I know that'll make a lot of providers happy, throughout the community. EMS, thank you for approving the order of the new rigs. That order has been placed, and hopefully they're due to arrive in about a year. Roger is retiring. His last day is the end of the month. Chris, we interviewed Chris Tumlin, and he has offered him a position, and he has accepted. So he will be the new director of EMS. It's going to be a good fit. Him and I have worked very closely together the last 3 years with emergency preparedness, so I think it's a good fit, and I think he'll do a great job at leading that team. So, with facilities, big things going on is seclusion room. We have about 2 items left on that, and then we'll get through the permitting and get through the Department of Health. They'll have to do a final approval before we can open up that room. Hopefully, in the next few weeks, that room will get opened up, because we do have boarding issues in the emergency room, which is putting extra strain on the staff in the ER. So excited to get that up and going. We're in the process of finishing the PFS building. I will be on next Tuesday doing a walkthrough with Scott Price, the owner of that building. So if you've been in that building, there was a lot of cubicles in there. We had to get those all tore out and taken down, and the room building kind of put back together. So we're just finishing up some wall patching and painting, and that, by tomorrow that room will be complete. We're going to get the building thing done on Friday or on Monday, and then we'll final walkthrough on Tuesday. So, and we continue to get, prep.
Excuse me for a second. So that's that former pharmacy across the street. Is that what you're talking about?
Patient financial service building.
Yeah,
Yep, right next to the light
Yeah.
plate. Yep. So that's one more building that we will eliminate from having to lease. So it's a good thing. We are pretty close to finishing up the boiler chiller project. We are the contractor. We've had some issues with the hot water regulating the temperatures, which has caused issues in surgery. They have been really pushing them to get this resolved. We have a very old building. They're going to update and change out the mixing valves that control those temperatures to digital ones, which is kind of the new thing that they're doing, especially in the old buildings, because it's hard to control. There's so many legs that are attached to the system, and they're all different pipe sizes, and it's hard to control the pressures and everything. So hopefully, within the next week, that can get that resolved. So I know that'll we've been, my team and the OR team has been inflicted with a lot of overtime trying to get the scopes clean and keep the equipment running. So we're hoping to get that resolved. We are not going to do final payment on that project until everything is operational rich. So that's a quick overview of everything. If there's any questions. Well, in my spare time, I want to mention one thing. So we're looking at going to a centralized registration. And there was a lot of concern with staff because we're short on staff. And our facility we don't have the right layout when we enter the building. So we did a rapid improvement that yesterday. We got all the departments together, oncology, DI lab, PAS, and the clinics. And we kind of went through the process, found where our stop points were, and came up with some action plans to resolve this. We are not going to move as planned on Monday into a direct centralized register. What we are going to do is the lab people are going to learn the registration so that they can do full registration. That'll help support PAS, and it will prevent us from losing some more staff because lab people were not going to, they were refusing, they weren't going to sign the FAR, they would just quit, which would have put us in a worse position. But we came up with a lot of good flows and ideas and action plan items that we're slowly working through that'll actually reduce the workload on the PAS, and it'll be a better experience for our patients when they come in. So it was a very good meeting. It was about 4 hours that everybody put work into this, and it was a good outcome. So that's the last time.
So this central registration would cover all aspects of the facility?
At some point, yes, in the future, that is the plan. We just right now don't have the staffing and we do not have the layout. So the buildings just not properly, the way you entered, people can get by the front entrance where they would go to register and they end up going to lab and they end up going to the DI counter and then they have to be sent back. Or if they do show up at the lab and they have a lab appointment, they get registered, but then they have to go back out to the front to re-register again to go to DI. So it's gonna keep that more efficient and cause less work, and it'll keep the patients coming in a lot faster rather than standing in the line. They'll be able to go to multiple places. Serves the same purpose. It's just a little bit different, structure than what is planned for the future.
Yeah.
How many years has Roger been? in
40.
Yeah,
It's honorable.
it is. Did an amazing job. That is, an area that shines in this organization. And we greatly
And in the
appreciate it.
communities, not just in our organization, but the
Yeah.
communities and all the various classes or events at the state fair or county fairs and what have you, where they're always present in school events. And a great job at the communities.
Project first came on board, we had 2.5 ambulances. We had half of one here at the hospital. And there was eight EMTs that covered the whole line. And we built it up to like this. And the fact that it's recognized, and they'll have people coming here from all over the place to look at how it's set up. I think you're right, the handoff is going to be really easy. Okay, thank you. So that covered the facilities report also, and so we move on to nursing. Curtis.
I'll make it quick. I just wanted to echo what Carolyn said about swing beds. That has really started to take off. We currently have 4 swing bed patients on the floor at this point.
Good deal.
So we are swinging up the right way, no pun intended.
That was a fun.
There is more education that needs to go out as we work with our partners. We're not lacking referrals, but we're lacking referrals that we can accommodate. So the education process, we continue to educate our referral partners. But we're of course taking every referral very friendly and kind, because I'd rather have them come in and us say we can't do that than no one call. So we're working through that. Real quick on all the departments, our OB, we're looking to get a traveler, and I think we hired one today. I know the travel word's a bad thing, but it's a good thing we need them because we're growing.
we're edging right up to the 31st a month again. And we haven't got our full complement of OBGYNs on the floor yet. So we're anticipating that, trying to grow. Tabitha and I have worked really well together. We reached out to a previous employee who was a wealth of information and very strong in education. To see if we can partner there to do some more education with our OB, our nurses, because with the turnover, we've lost a lot of talents. We want to make sure that we have a robust nursing team as we continue to grow our OB. Emergency room, we talked about the 17% increase, and yes, we are feeling that. We're averaging between 55 to 65 patients a day. That's considerably up, considering just a few months ago, we were down in the 30s and 40s. With that said, that also comes with a constraint of staffing. So you're going to hear a continual theme. I think it's with every single department in the hospital. But we're working our best to do that and get it going. We did sign on a traveler who will start Monday, which is really going to help. And then we reached out for an additional traveler, despite life goes on regardless if we're short staffed. And we've had a few people drop out with illnesses and a couple with FMLA needs. And it's come to a point where it's our people care enough about their employees that they apologize that they have to take time off. And so it makes me sad as a leader that people feel they have to apologize when life happens to them. But it also makes you satisfied understanding that they understand the impact to their coworkers. And I think that's what makes a really strong nursing team and how we've been able to pull and help cover each other. ICU, it's been a little rough. Some of the doctors have had an issue with us dropping down to the census of 2. But we're finding now that that's working. You realize that the overall demand is not there. The occasional need here. It does get a little rough because I-5 corridor is full. So all the hospitals are filling up. So COVID has reared its big head again. We're not getting hospitalized, but there's other comorbidities going on. And I think that's part of the problem. With that said, we've got 440 in ED that we're trying to find placement for, which already causes stress to the staff. And I've got 2 on MedSurg. And you've got to have the right discharge plan for a couple of things. One, we want to make sure patients go where they're safe. And also we want to avoid readmission. So it's not as easy as, okay, let's go. Social work works really very hard on that and have done a great job of trying to find placement and work with different agencies, but it's starting to be even more apparent the need for additional care and services in the nation. We're looking as far as Idaho and Oregon for support on some of these people. And it's sad, but we'll continue to work on that. Hospice. They're growing their census again, which is really exciting. We have extended an offer for a manager for hospice, which will be great. And that contact started yesterday with HR. And what's really exciting is we all look to change. The move from hospice to a hospital was brought with a little bit of this. One person who was very vocal, and I appreciate that because I think you have to hear all sides and what people are feeling. Sent a very nice email on, I changed my mind. This move turned out to be good. And that I kept and I forwarded on to administration because it just shows, everything that we're doing, whether it's hard at this time, it's been done with thought and for outcomes. And people are starting to realize we're starting to turn that corner. Okay, well, this isn't a knee-jerk reaction. This is something that's been thought out. And what was even better is it wasn't so much just the change in moving over here. She saw the benefit for the patients. So this is a good outcome for our patients, and that is what it's all about. So very excited with that. Oh, our PACU. We continue, we have an offer out to a manager there who has accepted, and that's being finalized. We have been successful in recruiting 3 additional circulators. One is now doing her buddy call to circulate after hours. The other 2 have come on and are working fairly quick. The manager was currently taking, or the new manager was taking circulator call and working with OR as well. So the traveler thing is coming up once again, but I'm hoping we can continue to find a permanent placement, but to get him into Fremont so he can get in his role and keep OR as we look to attract more surgeons. I want the OR to be ready. So as we start to grow our OR suite, that we match those surgeons. So that's working. And I think overall, I just want to say it's all departments working together in the hospital, even our extended downtime of IT. The work everyone did together and the preparedness for it is phenomenal. The silos are breaking in this hospital, and it's neat to see that because being a small hospital and all of us having to share in the load is evident that we've got the right team here. And yeah, we've got a superb staff, and couldn't do the work we did if we didn't have them. So kudos to everyone from housekeeping to our surgeons, to our nurses, our CNAs, patient access. There isn't one person that hasn't made this transition work. So got a good team. And that's it for the master.
Curtis, I know that we don't like to hear about travelers, but it's kind of nice to see that you're meeting them right now because the volume is picking up in so many different areas. And I know you're working hard at, get permanent people in, but it's just nice that, to see the volume start to come back, people have
The
not-
volumes are coming back, and I think the other thing too is there comes a point where you have to have your staff safety and most importantly, your patient safety. But it helps with morale, and they realize, okay, we're not just getting more and more on it, because I don't think anyone walks through the doors of our hospital today that doesn't want to do the best job they can. And so it's hard because the old banker side of me and the nursing side conflicts. I'm like, okay, I know this money, but then okay, let's over here. And so it's been very supported by Kelly and Mike to say, if we need it, we need it. The other thing that's really neat is Connor has done a great job on promoting and helping. He's got really neat flyers they're going to have there. And so I'm anticipating that will start to generate some more interest. Because we are on an island, we don't have potential candidates driving by us over there and go, oh, I wonder what they're like. But we've got to have something to pull them in. And he's done some really great work there. It's neat.
You might want to give them an update on the market rates that we're paying for RNs now.
Yeah, and that's true too. I think last meeting I mentioned that the travel agencies are getting hungry. They really are. They're almost annoying now because they're constantly calling. They're trying to find placement for their people. It's working into our advantage now. I want to say we're probably the average rate that we were paying versus today's rate is nearing almost $60 to $70 an hour less. So that's working in our favor, and I think it will also, as that starts to drop, you remember those rates that the agency's taking a lot of it. The nurses are getting some, but the agency's taking a lot. I think we're going to start seeing people return back to the regular workforce because if the money's not there, that's a hard lifestyle to live. So keeping our fingers crossed.
Good news. Any questions for Curtis? Comments? Thank you, Curtis.
You're welcome.
Moving into a human resource report and then the admin report, Mike.
I'll do human resources to start out with, and I'll move into the operations.
Sounds good.
From human related, HR, we have some high level recruits going on right now. Director of HR will come in and interview in about 2 weeks. IT director, we have 2 or 3 that we're looking at right now, and the director of products. Those are the main areas that we're looking at right now. concern in HR right now, and it's a hospital-wide concern, is the ability to recruit and retain employees and attract them talent. Talked about a lot of different areas here in the hospital right now where we have shortages. You just mentioned the shortage. We have to go back to bringing in traveling nurses. We have a lot of openings. So one of the things we looked at, we have openings throughout the hospital, is our turnover rate. And our turnover rate, I believe we heard it this morning, was somewhere like 40% last year, 35 to 40%.
In that range,
In that range last year. This year, it's very similar. The benchmark for turnover rate is 4%. Turnover costs us, it's probably this 30% probably equals some $500,000, $700,000 just in turnover. I think anybody in the business here would agree with that. So we need to find a way to bring it down. And we've looked at our wages and salaries, and we probably need to begin to look at that some time. So we do have a Mellman report in that lets us know where we are, and we are still below. I think this board will need to address that in the coming. So that's basically the HR report.
Move on to administrator.
The administrative report. You mentioned a while ago, Mr. Chairman, that we have pretty much stabilized the hospital. We're in the first phase of stabilization through the hard work of this team, board, and a real yeoman's effort by the medical staff to come back together with us and work with us. So we're stabilized first phase. We've probably got 2 or 3 more to go. And you mentioned we want to survive and thrive. So 2 things I'd just like to talk about is we need to continue to grow the services that we got going right now. 2 of them that you mentioned, swing bed, we could continue to grow it, and push it ahead. We need to really begin to market and grow our women's services. So those are 2 growth engines that we'll have going forward. And we soon will have 3 OBGYNs in place. We hope by October. We have 2 now. Really good chance of getting the 3rd one in by October. So 3 OBGYNs. We delivered about 170 patients in the last year here. 900 were delivered from this island. So that's a shame that we can't meet that need. We think we can now once we get back to promoting. We've also, just as a little side, as I'm running through this, go as quick as I can, we have encouraged the foundation to look at some of the larger companies in Seattle. The funding, there are some worldwide companies over there. And I think we've got a very compelling story that the foundation could present to these large companies. We want to grow human services. Some, whatever, 700 women had to leave the asylum, get their pre-care, baby after care. So that is not a good thing. So I think we have a compelling story. Maybe we'll begin to get some support in that area. Which leads me to, we can't rest on our laurels. We need to be looking to the future. What other growth engines are we going to bring into play? And one of them is a 2-pronged, I think it's a 2-pronged strategy. We want to keep our rural health clinic that is in Freeman. We don't want to lose it. We had to close it because we could not find appropriate staffing on the provider side and then on the employee side, both sides. So we closed it. So somewhere around September, October, and Dr. might help me with that, we can possibly lose that status. So how can we keep the Freeman Clinic open? So that brings me upon a new service that we can provide, which is behavioral health. And Dr. Lemmy has had us approved a category for a clinical psychologist. So Like to just talk for just a second, behavioral health is one of the major needs across the nation. I think we sit right up there with cardiology, this one of the areas we're talking about. Certainly it's on this island, there are some providers on the island, the health department provides some services, and then there are other providers. Think of three providers just opened an office in Oak Harbor where they will provide telehealth services for behavioral health. And you can walk in and get some services for cash. So there's all kinds of services going on. We'd like to plug that some gaps right now in our behavioral health ecosystem on this island. We can start out with behavioral health by bringing in a couple of providers, a clinical psychologist, 2 nurse practitioners. Put them in fairly thin is an idea that we have. So if we could get going with that, we could, by September, we could maybe save that license. Our reimbursement rates are in the $270 per visit, which is excellent. It's really be nice to get in there and get that going. We're talking to a couple of these folks over the next 2 weeks. This is another aside to that, though. Garth would be very happy to let's open that clinic up for the providers. But he will not be so happy when he tries to go out and recruit staff to support them because of our rates, the low rates that we pay our people for medical assistants and registration clerks and all that. So that's good news and bad news. That's why I said we need to get this. The program, as we bring this in, would be a outpatient program, not inpatient, outpatient. We can do MAT services in there, medically assisted treatment services in there, and where we could prescribe Suboxone, substitutes for opioid addictions and any other kind of addiction right now, pain addiction. We can do IOP is what it's called, outpatient therapy or group therapy. Group therapy happens when you're discharged from an inpatient psychiatric hospital in Seattle, bring the patient back here and you put them in group therapy to help them transition back to a normal lifestyle. And a lot of this will be underpinned by telehealth. We provide telehealth services at the convenience of your home, your car, anywhere you want to get services. And we can do it 24/7 once we get moving into it. So that's just some of that. I sent you all out some information on that already. The other, as I call it, 2-part strategy is we're talking to some family practitioners right now, the internist and a nurse practitioner, this afternoon, to see if we can recruit in there. Compliments of Dr. Farron over the corner back there. Best people to recruit providers. And so he's helped out a lot. So we appreciate your work. Okay, it'll work. So we'll take a look at that this afternoon, and possibly we could get a robust clinic started back up. If they, or maybe even some of them may swing back and forth to the clinic. So that's a little bit on that strategy. Just want to throw it out there. So I believe that's the main things in our report. Questions?
Any questions for Mike?
I just have a comment about that mental health thing is just absolutely huge. You're right. I think we need to tap into that. That certainly is a need in our communities.
I've talked to some physicians and they have these patients, family practitioners, internists coming into their office. Recognize they have some problems, but they don't know exactly what to do with them to find the right help. I think it'll be really good for us. We will continue to talk with the health department and the providers to niche in and look. I think there's a huge host of plenty of patchwork being done.
Sure.
I have a question. What are the thoughts on ways that we might be able to attract more of the support staff, receptionists, the MAs, et cetera? Is there any plans along those lines?
Well, that's what I just mentioned. I think the board will need to address that with help from administration. What to do about wage scales. We need to do something. We're just beginning to stabilize the hospital. Our days in cash are at 30, we're growing. We need to be at 150 days in cash. Accounts receivable days are coming down, which is good. So we're showing some really signs of survival. And but to do that, one of the biggest things that when Neil, president of our company, was here, we were just talking about, what's the biggest issues you see here? And it's number one, many things, challenges we have, was your wages. We've got to get our wages back in order. So that's our challenge. And we're working right now, management council, right now, some ideas about that. So we'll be bringing those to you.
Question for Mike? In here on item 6, we have general board items, approval of contracts. Are there any, we need to bring that up. Is there any contracts that need to be moved forward and
No.
Yes, James?
We want to improve the board meeting minutes from last time. We need to go over it.
It's in the consent
Is
agenda.
that what consent? Yeah. So moving on to, this is the commissioner's moment. So if any of the commissioners have any additional comments, or questions of anybody?
Yeah, I want to say that my people assembled an outstanding staff. You guys are really impressive. I'm practically blown away by the job that you guys are doing. I think you've done a tremendous amount. But what you guys have accomplished, I think it's just phenomenal that you've been doing. Just want to tell you that. I appreciate you very, very much.
Well, somewhat along the same line, I am amazed at transition in, I'll use the word culture amongst the various departments. For so long, they were silos of one sort or another, and they truly are beginning to work together much better. And I think when they're working together, they themselves see the benefit of it. And they realize that it's a better way than what they have been doing. So lots more smiley faces around, a lot more happy meetings, and but it's a good feeling. It's a good feeling. Plus, not only is it a good feeling, it's good to see the numbers, financial numbers changing. And of course, that was a major, major concern of ours when all this transition happened. So thank you to Kelly and to Jim, who was here, and to Mike for leading the charge as we go down the pathway.
Dr. Kammermeyer, do you have any comments, questions?
Being remote it just mutes me. No, I don't have anything to add.
I just got back from a seminar last week, or this beginning of this week, I should say. It's rather interesting. Chick-fil-A. Competitive pay, among minimum competitive wages, $15 an hour part-time, $16 to $18 an hour otherwise. Flexible hours closed Sunday. We will arrange your work schedule around them. All Chick-fil-A's are closed on Sunday. College scholarships at Chick-fil-A, we believe in everyone deserves an education. We offer leadership scholarships to eligible employees who qualify. It's a friendly place to work. We consider our team to be more than just employees. Our goal is to treat everyone with honor, dignity, and respect. Free employee meals. Just goes on, and it's just kind of like holy miracle. Yeah. How do you? And I think they have healthcare.
that's part of our competition. We always talk about Island Hospital and hospital, healthcare competition, but there's competition for our lower level employees here. Our frontline people, registration people, make far less than $15 an hour.
So, there again, I mean, I think the one thing that I think the board gets to take credit for is that we made the right decision on bringing health tech on board. I think that's what we're hearing too from the board members with that. It was the right move that we needed to make, and it's really paying off. Very impressed with how it's all pulled together. So, hindsight would have been great to have done it years ago, but you know what, I think we did it for the we're able to pull it together, and I think we see that throughout the different members that are here, you know, that Curtis has seen the changes, Jim's seen the changes, you know, there's a lot of these people that have come forward and said, you know, night and day difference in how things are operating. So we want to give the attaboys to help that they have lifted up so far, other than 150 days that Mike's committed to cash on hand, but Health Tech has lived up to what. A lot of times, you know, when we do hire somebody, I don't care if it's health tech, architect, engineer, you know, whatever. You're always taking a gamble on what you get. And you know, look back and it's like, is that a good college back then? I really see the results. You can pass that on to higher ups also. I mean, the attaboys and the commitment that you Kelly made. Just days, cash on hand.
And as an aside, Eric, are you gonna bring Chick-fil-A to the city?
Well, at this time, then we'll open it up for any public comments. Is there anybody that's online there?
There are 26 attendees. They raise their hand, I can allow them to talk. Anyone would like to make comments?
Well, while we're waiting for anybody to come on, there is Dr. Wagner, you are here in attendance. Do you have any comments or anything you would like to bring up?
I'm gonna echo your comments. We've been impressed with the momentum that Health Tech and Mike and Jim and Kelly have brought. And I would echo your comments that we're very pleased. People are feeling that there's good momentum being built and that we're heading in the right direction.
Don, anybody raise the hand? Yes. Well, then, at this time, we are going to go into executive session. I want to keep Tim here. Sure. So I'd like to, you know, keep Tim around and Kelly also. I'd like to keep them around for items that we want to discuss. And Carol, say that. And no decisions will be made. It's strictly information, discussion of employees.
Will somebody call me?
Yeah, we will. I would say to give us 30 minutes. An executive session, so we'll be going out here at 1:30 and be back in at 2 o'clock. Back on. Okay, we're back in session here. Discussion, but no decision, no voting taking place in executive session. Basically, agenda for the next board meeting, we have our work session on Thursday, July 7th at 1 o'clock, and then our next board meeting is Thursday, July 21st at 12 o'clock here. Any other, if anybody has anything they need to add to those work session or to the board meeting, then just make sure you get it to us, so we put it in there. Other than that,
I move adjournment.
Second.
moved and seconded for adjournment. All in favor?
Aye.
Thank you, everybody.
Bye, Greta.
Hi, Greg.
Okay, I didn't mean to stop you, but